Welcome to Season 2 of From Girl to Great, where we explore the economics of health and opportunity. Today, I am thrilled to be joined by Sarason Kahan, a globally recognised health economist, advisor, and trend weaver. Jane spent over 30 years shaping the future of healthcare, working across public and private sectors in both the US and Europe. She is the founder of Think Health, a consulting firm that helps organisations navigate healthcare strategy and innovation, and Health Populi, her blog that explores health consumerism, policy, and digital health trends. Jane has been recognised as a top 45 digital health influencer, and her pioneering work in digital and retail health, health literacy, and patient empowerment has transformed how we think about healthcare. Jane, welcome to the show.
Alana, thanks so much. And yes, I think you're not just good, but you're great too.
Thank you very much. So right out of graduate school, you went into healthcare consulting and you were a health economist. And I was wondering if you could tell us about your journey into health economics and what drew you to this field.
Sure. The origin story about me and health economics comes through my mother's experience getting diagnosed in 1971 when I was a young teen, adolescent really. And the diagnosis she had in a very rare type of leukemia. There was no chemotherapy back then. It was very medieval treatment. It was a lot of zapping of radiology and a lot of blood transfusions, which is the medieval part, really. You think about like leeching in the Jane Austen movies, and it felt that way back then. But she outlived her prognosis. The economic part of this, in addition to that health experience over 8 years of the arc of that disease, dying in 1979, was that after that 1979 last trip to the hospital, last 13 days of life, that medical bill, even back then in my father's EOB that he received, the explanation of benefits from Blue Cross Blue Shield of Michigan, was over $100,000 in 1979, October 79. And I was then in high school, not in college yet, but interested in economics and politics and such through my father's influence. Long story short, I was always wondering who was paying that bill, because my father only covered the television in the room and the telephone. Literally, there was now that was the glory days of 1979, a union influenced health plan, because we lived in the state of Michigan outside of Detroit. So that's how such things worked at the time. What we would consider today as a Cadillac plan, not just because I'm from Detroit, but a very rich health insurance plan. I have this thing in my head as I entered undergraduate school in economics. Ultimately, I returned to University of Michigan, where I did my undergrad after a few years of work experience in different sectors, not healthcare, to do my work in health economics at Michigan in the School of Public Health and then the Department of Economics. There was no integrated degree at that time as a health economist, but there was a pathway to do that between the Rackham Graduate School, which was the economics part, and the School of Public Health, to which I am devoted to this day as a passionate alumni. Go Blue, go Wolverines. So that's the origin story through personal experience. And we see this, whether it's in public health or whether somebody becomes a speech therapist, where you have a personal experience and it informs your heart, your head, and your spirit to learn more. And so that's all I've ever done. After finishing graduate school at Michigan, then the career move to Philadelphia from Ann Arbor, being hired by a boutique healthcare consultancy called Health Systems Incorporated, which grew out of a health architecture practice in Boston. And they were coming down to Philadelphia to broaden the consultancy beyond building, asking the questions, what should we put in the buildings, whether it was a heart unit, breast cancer therapy, whatever. So I became the young analyst for 3 principals in that office. And, the days of the big compact, you won't know this, you weren't born, but the computers we used looked like sewing machines, with a handle, and you carried them around, and they were bloody heavy. And because I was the kid, I carried it on the airplanes. But the experience working from Maine to California to Florida with a firm like that, it was brilliant because the learning curves were just constant. And then I grew the career when I moved to London. I'd fallen in love with an American banker named Robert Kahn in Philadelphia. He moved to London to manage the branch of his bank, the Philadelphia National Bank at the time. And we eventually got married and I moved over. And then I got to experience as a consultant with Touche Ross, which is now Deloitte. I got to work part-time with the National Health Service, the biggest single payer in the world, and part-time in the private sector. As an American coming over, they were delighted to have me help them with the burgeoning private sector, BUPA, health insurance, mental health, rehab, lots of these services that at the time the prime minister was trying to privatize a little bit. And so I got a really fabulous experience. And in addition to health services, I also cut my teeth on pharma and medical technology then, as imaging was getting more, digital imaging was getting more advanced. And then electronic health records, EMRs, electronic medical records in the NHS were more advanced than in the US, because in the US it was all about billing, capturing financials. But in the UK, we were looking at both resource utilization, so labor, capital, etc., but also some outcomes measures. While we tend to diss a lot of people in the NHS and outside, at that time, my experience was that I was getting a more rounded view on and more integrated EHR type programming worldview lens than in the US, which was bill, DRGs for Medicare, get paid the maximum amount that you could for a diabetes episode, a heart episode. So that really helped inform my digital tech chops, so that when I came home then later on in the 90s, I was ready to ride the wave of the internet and healthcare at that point.
Fantastic. And absolutely, I love that you were inspired by your youth to go into a career that you're passionate about. Because I think that's really helpful to be happy in a job and feel passionate about it.
It's so important, and I know your listenership is all ages, but particularly from girl to great. We want to mentor and share our experiences and all of the scars and be honest about all of that. My great friend, who's you could consider my sister in healthcare, Lisa Sunan, who's known as the Venture Valkyrie in her blog, now heading the ventures at American Heart Association, she was recently appointed one of Forbes 50 over 50 women. And her advice, and you can see what she shared on the Forbes site in her biography that they put together, but it was really choose workplaces where you find joy with the people and you share community. And I think it was brilliant advice, because I was very fortunate as I worked in Europe, back here in the US, and then back and forth, sometimes in Brussels, sometimes in the Philadelphia area, but between the US and Europe. It's really the people and the joy and the shared commitment for me to ultimately public health, population health, public health, from the individual to the family to the community to the world. So Lisa's advice is well taken, that you find joy in that hard work, because we're working hard. So find a place where you find community too.
What did your work as a healthcare consultant with the NHS and private healthcare in Europe involve on the day-to-day basis?
So I was American. I wasn't yet a European citizen. Not that that would do me any good in the UK right now, but as an American, the firm really wanted to hire me to bring some of my learnings about resource allocation, utilization. How do we get bang for buck or bang for pound? And that, so we talked about value back then, different than how we talk about value-based care in the US today, which is an ongoing thing. Value for money is how we were putting it in the UK and the NHS. So a lot of my work had to do with observing workflows in different situations, whether there were surgery units or mental health units. Some of the mental health units in the NHS were getting privatized, and we were trying to figure out how to repurpose facilities or human capital workers. Ultimately, I would move into strategy more in the private sector than the NHS. The NHS was still very underfunded. I think it's still somewhat underfunded now. So I got to do some of the good strategy work that I did in mental health and rehab, particularly with a U.S. rehab organization that I won't name, but that came over to the UK. And we figured out that strokes were not getting well served in terms of stroke victims, stroke patients, in the quick, aggressive rehab phase where people could recuperate more holistically and wholly than they were in the NHS system. So I did a bit of work in rehab and in mental health when Boy George was singing, and he brought attention at that point. Even then, celebrities were playing a role in informing the public. So it was different in the public sector, which was more resource review, utilization, tweak for value for money, versus what the private sector could do that the NHS could not do. Rehab for the people who could afford it. So, I mean, this is it. We have a multi-tiered system over in the UK.
And with your extensive international experience, how do differences in funding models, like between the US versus the UK, influence access and innovation? Why does the US often lead in innovation but lag in access, while other countries like the UK have broader access but have more modest startup and investment activity?
That it's a tremendous irony that the US spends more, and every year we end up lower and lower on the Commonwealth Fund list of countries by outcomes, except for cancer, which is the one place, if you get cancer, you would tend to want to be in the US to get treatment. I'm not saying it's perfect at all. Ask a cancer patient in the US and you'll hear something different. But in terms of outcomes and access to innovative treatments, the US scores high on that, but very low on something that I think is the pillar of precursors to good outcomes, and that's primary care access. In the UK, because I worked there and lived there, I had a national health insurance card and a general practitioner, a primary care practitioner assigned to me near where I lived in Chelsea. That was my on-ramp into healthcare. Now, if I wanted to opt out for certain things like a quick pap smear, I was in the private sector and went to my wonderful doctor in Knightsbridge because I lived near there. So how does funding predict or shape access? In the US, we still have largely fee-for-service or discounted fee-for-service. So we spend for every bandage, every visit, every image, every lab test. Whereas if we have a budget, which we have in the UK and in many EU countries, who all fund differently and treat differently. Healthcare is still a sovereign thing based on design in Germany or Denmark or the Netherlands or France. But I just named you 4 countries where outcomes are terrific, where there's some budgeting involved. And when you have a budget, you tend to be more disciplined about how you spend your money. Heavy on the primary care. Let's keep coming back to that. Primary care, and then social care, social safety net, nutrition, early childhood education, daycare, after school care. Ultimately, we look at Scandinavia for heavy duty for that and heavy taxes for that. But that then sets up a child from prenatal care through school for lower risks of the social determinants of health that can really cut a person down in their childhood and teens in terms of what their future health will look like. Education, food, clean air, clean water. Access to health care is a social determinant of health. That on-ramp to primary care is on the list. We often think of social determinants not having health care in them, but there is in terms of access. So I think if I had to pick the one thing, it's education first, sets you up for a good, healthy life, and then access to primary care. And you see very different allocations of investment and speaking very generally here, from the European, EU countries and the UK versus the US. And I wrote about that in my first book, Health Consuming, where I have the chart that shows the difference between what the US spends on social care, those SDOH things, and healthcare. And it's very inverse in terms of what OECD countries spend. Again, it's just topsy-turvy. I think that's a huge factor to look at, and many others. There's some bias, institutional racism can be a factor in terms of access, just women versus men, Mars Venus stuff, black versus white in America, or black, brown, and white. Native Americans, health status tends to be much lower. Lots of history behind that. I'm involved in the issue of health disparities and what can we do to even things up. But when the playing field from prenatal care is stacked against you in terms of your mom's access to prenatal care, vitamins, good food, scanning, sonography, you are already setting a person up for a lower level, potentially, of thriving over the course of a life. And I like to think about, in my advanced part of my health economics career, going beyond looking at what we spend as a portion of GDP, gross domestic product, and more think about how do we invest so people thrive and flourish. And there's more and more literature on this in our peer-reviewed publications, in Lancet, in JAMA, in New England Journal, on the concept of flourishing. We want people really to flourish. I want people to flourish. So at this stage of my career, when I'm putting different collaborations together between retail, private sector, public sector, it's how do we help a community to rise up together and flourish based on food, clean environment, exercise, mental health, social health. It takes that whole village. It's not just one thing.
Yeah, absolutely. And if you look about like what kind of food people are consuming, the landscape has changed a lot in my parents' lifetime, because when I go to America, I find that unhealthy food is so much cheaper than a packet of fruit. Whereas in England, like an apple is going to be cheaper than a pack of candy. So like things like that definitely affect people's diet.
When I live in Brussels, I get to shop at a grocery store called Proxy, which is part of the larger Delhaize company, big food, big grocer. They give me a 10% discount at checkout when I buy the healthier food. So we tend to eat a lot of salmon and fish, and then healthy, lots of produce, Mediterranean dash diet kind of thing. And I get, when I'm walking out, say it's €100 bill in Brussels, it's Belgium, it'll be 90 euros. Literally, I'm saving 10 euros a week on that grocery bill because that company has decided to incentivize people to live healthy lives. And the price is also astonishingly good when I'm buying in Brussels, even in pandemic and post-pandemic, because the agriculture sector is clearly subsidized in some way and incentivized to produce more healthy food. Versus in the US, we still have the corn subsidies and sugar. So yeah, it's so much cheaper to buy an apple, berries in season, and other beautiful things.
Food is medicine. What does health consumerism mean to you, and why has it become such a critical principle in today's healthcare landscape?
So I have the scars on my back and front that I bear, having not originally coined the phrase health consumer, but used the phrase health consumer for at least 20 years now. And my great economist hero, Paul Krugman, who until very recently wrote in the New York Times, brilliant economist, he once wrote a column a long time ago, said there's no such thing as a health consumer. For me, though, I absolutely would arm wrestle Paul to this day to say yes. People are consumers, not all the time, but when I started to really, really own that in my practice of consulting and being associated with that phrase in some of my consulting work, was when I was working with a big pharma company, top 5, around 20 years ago, with one of the diabetes franchise groups. So it was one of N number of companies, very big in diabetes and way pre-GLP-1s. We're looking at insulin and the pills. And at that point, we saw in the PBMs, the pharmacy benefits management companies, co-payments for drugs at the point of purchase in pharmacy. We didn't have a lot of mail order yet then, so I go way back. The copay would go from, say, $0 for generic to $5. Then we saw it going from $5 to $10, and then $10 to $20, and then to $40 for a drug not formulary, meaning not approved brand. So generics were considered the first tier, tier 2, approved brand, higher price, then tier 3, branded, not on the formulary. And then we were just starting to see tier 4, the specialty expensive drugs coming in for co-insurance. So say 50% of retail. But I'm going to focus on generic, tier 1, tier 2. We saw those broadening to the point now where that tier 2 branded non-formulary drug could cost $40 to $20 bills at the point of purchase at the pharmacy. So I brought up to the drug company franchise group talking about pricing and marketing, commercializing a new drug. Mrs. Jones presents herself to CVS, Walgreens, Rite Aid, Walmart, Target, one of the pharmacies, to fill her husband's prescription for X. And it's also Mr. Jones's birthday. So she's got a budget and she wants to get him that Norelco razor for the birthday present, but she's only got, say, $50 in her wallet. What does she buy? She does not fill the prescription. She goes for the razor. And at that point, when Mrs. Jones is confronted with an out-of-pocket spend for a drug versus a consumer good, she's a consumer. Whether we think it's good or not, and that's where I think I was dissed early on, because people would say, well, that's a terrible thing. Economists, some of us make judgments, some of us say, this is it. This is the data, or the reality is the reality. Oh, this is how it is, right? Like my father always said, it is what it is. I spotted that at that time, and that drug company was quite savvy because we figured out patient access programs then, how to get people on board at heavily discounted drugs way before GoodRx came to be. So we spotted that early in my little world and made it work. And now, of course, got patient access programs for very expensive oncology drugs, Parkinson's. Every expensive drug has a patient assistance program associated with it.
Yeah.
And at least helps people access who may not be able to access these products.
So I'm presuming that copay is when the insurer pays part of the drugs bill and then the person taking the medication pays part of it up front. But as someone foreign to the US healthcare system, how does the health insurance work when you're going to collect a drug? Because I've gone to America with type 1 diabetes and accidentally brought the wrong type of insulin. So I had to get a prescription filled. And luckily we knew some doctors, so they knew about this program where we could get it at a lower price, but it was $50 where I normally pay £0 for it. So, and I know there's a different, so there was a big price for the insulin, but then it was cut down. So how does that different pricing system work?
Works differently for each consumer/plan member, depending what your health insurance covers. So we have Medicare for older people, Medicaid for people with lower incomes, people in the Veterans Administration system. Each of those populations is treated differently with respect to medicines. Medicare has what's called the Part D. Medicare is very complicated. And I'm speaking very generally here. There's a lot of nuances. But an older person who's on Medicare has to pay out of pocket up until $2,000, and then medicines will be compensated that are approved on the plan. We'll get back to the plan. And then on the commercial side, for employed people who have a commercial plan through their employers, through UnitedHealthcare, Humana, many Blue Cross plans nationally, etc., you have about 50% of Americans covered through employment and 50% covered through the public sector through all those other plans. But every individual who has health insurance also has a prescription drug plan. Those can vary tremendously in terms of what the co-payments are at the point of purchase. Increasingly, if you are taking a generic drug, or in your case, for your special insulin or other drugs you might be taking to complement that, your drugs would probably come mail order because they're very common and regularly used. So the more generic a drug is, the more we can get it via mail order, which is even cheaper. Say a 90-day supply for like $30, depending. Walmart introduced that many years ago. Really inexpensive 90-day supplies for generic drugs like statins that are generic. So the lower risk things. But it really depends on your drug plan. And that's where in the US right now, we've had a debate for some years on the value of the intermediary between the drug company and the health plan and consumer, which is the pharmacy benefits manager, PBM. And years ago, when Donald Trump ran for the first time for president, won and sat for a Time magazine interview, Trump said, we're going to get to the PBMs. We're going to get to the price of prescription drugs. And of course, that came and went his term. Biden came in. Biden put some things in the IRA law to reduce the price of insulin, to reduce the burden on seniors, et cetera, et cetera. But we haven't solved the problems or challenges with PBMs as the intermediary yet, which cut out a lot of the savings that aren't necessarily delivered to the employer or the consumer. That's the profit margin they make, and it's mighty. So we're now getting more transparent about understanding that. Anyway, to your question, it depends on your health plan. Your copays will be different. The mode of channel that the plan wants you to use, mail order versus commercial or retail pharmacy, etc. And sometimes they even tell you which pharmacy you have to use.
What inspired you to start Think Health and Think Populi, and what has been the most rewarding part of that experience?
So I started the blog Health Populi in 2007 after my great friend Matthew Holt, with whom I worked at Institute for the Future in California doing forecasting. Matthew left that job, had another job, and then started the Health 2.0 community and the healthcareblog.com. Best name, got it first. It's still alive and great. And I really admired what he put together in the healthcare blog and talked to him. And he said, it's a time suck. Be careful. You don't want to do it. And I said, I think I do. So I focus. For me, I wanted to focus on my convergence of the consumer, healthcare technology, some health policy, and the economics behind all that. So it's really a very specific space that I cover, and that's what allows me to do that and stay sane, because I'm not boiling the ocean. I read new studies that fit in that little niche. That's my little box. And those are my guardrails. But it's 18 years later, and there are over 3,000 posts, all written by me, no ads, no monetization, nada. I do not make money on my blog. My mistake, that's how I set it up. What it does is gives me the thought leadership, so people invite me to speak, to write for payment, and as a consultant, to advise them on new businesses, to review plans, to help with scenario planning, which I do a lot of for my living. So the blog is just a joy. Think Health is my company, my advisory company, which I started when I left the big consulting world and wanted to become a mom. I looked at working women, and it's not easy. There is no balance for any of us working women who are moms. I mean, especially. I didn't want to have a full-time au pair. I didn't want to have full-time daycare. My husband was traveling internationally for work, so I said, I'm going to hang a shingle. And it was harder to do than it is now. I mean, I've been on my own now for almost 30 years. So Staples, the office supply company, was young, and faxes were shiny and yucky. There was no universal internet. I had to buy America Online for email. There was no Gmail. There was no Google. There were no smartphones. So I started, but I did it. I ramped up, and within 3 years, I had my client base in pharma, med tech, health plans, the people I work with. And the Think Health is the advisory firm where I make my money. And then the blog is Health Populi, and they're synergistic.
So what exactly are you consulting on?
I do strategy. I look at the future. I think about where's the puck go. I'm from Detroit, so it's hockey. So where's the puck going? How do you get there? Depending on who the client is. So if it's a pharma company launching a new drug in a certain area, we think about who's the ultimate consumer, the ultimate payer being the user or the caregiver, the parent, thinking about how do they interact with the company in terms of your direct consumer promotion, how do they react with their physician. So I do think a lot about prescribers too, doctors, nurses. They're part of my thinking of shared decision making between patients, consumers, and prescriber, and that's important. I don't look at consumers being all alone in the field, though increasingly people feel that way, and that's something I'm trying to help solve. Increasingly, I've been working with newer entrants to the health ecosystem. So big food companies, consumer electronics is a big part of my advisory portfolio now. We think about the things I'm wearing and the things you might sleep with that help measure or manage your sleep. So consumer electronics, food, financial services, looking at medical banking and the tragedy of medical debt, and how can I, as an economist, help inform that process, which is very difficult and very American problem. So I work with both that legacy healthcare system, big health plans and provider systems, and these retail health entrants who are going to help us solve the problems to cost, access, quality disparities. I see that working together, we can go further in advancing health equity and quality and outcomes.
That's such important work. How have you seen equity change from the beginning of your career to where it is now?
Well, we didn't even talk about equity a whole lot when I first started. But having said that, at University of Michigan, I did one of my theses on women's access to contraception and prenatal care in Detroit, which still got lots of problems in terms of access, equity, and low-income challenges. So that's been on my mind since college. How have things changed? Increasingly, we've recognized, bravo, that this is a real thing, and it's not just a woke thing, but it's an economic thing, and that there's a price to pay if you have persistent health disparities. It costs you a lot more in the long run in terms of overuse, wrong prescribing, underprescribing, overprescribing for, say, mental health. Well, we get people in the pipeline for primary care diagnosed early, a lot cheaper over the life cycle. But what militates against that is the way we've paid for healthcare. So if we're paying fee for service, cynically, a lot of policymakers say, well, there's churn, that person won't be a member of my plan, so that won't be my problem in the long term. So when we think about, again, in the EU or in the UK, where people are more health citizens, the subject of my second book, we care about people over their life cycle, regardless of who they are. We care that they get into the system of healthcare. We care that they get equal treatment or equitable treatment. And we care because we love our neighbor. That's a question now, particularly in the US, that I'm wrestling with now in terms of how can I still make an impact where information is not information for some people, the facts aren't the facts for some people. And it's a challenging moment. I don't think it will always be like this. I think it's going to take more than months to get through this funky time, I'll say. But so we have recognition now of the health disparities. Certainly the COVID pandemic brought that up. We could see it starkly, that people that didn't have access to Wi-Fi could not work from home, could not go to school from home, etc. And that social determinant alone, access to connectivity, was huge in Wi-Fi. And it made a big difference in terms of people accessing the basic needs on the Maslow curve versus, I'm going to realize my magnificence. We were just hunting and gathering for Purell and hand sanitizer and toilet tissue and basic protein. Like, it was tough. So, no, COVID taught us a lot about who had access versus who didn't and the health equity issues. But sadly, I'm seeing that there's a lot of forgetfulness a couple of years out from the long tail of COVID. I'm talking about the US now. I had a very different experience living in Belgium in and out of COVID. I was back and forth when I could get back and forth. I had a much more even-keeled health citizen experience living in Brussels during COVID than I did in suburban Philadelphia, where people were going postal in the grocery store, meaning really mean-spirited, and it wasn't a good look. And so I have the benefit of having these two lives, but it's very sobering also. So people think, oh, that's so cool. Yes, but like I think Jefferson has a quote that said, travel makes you wiser but less happy. And you know this because you travel and you're already learning that, yeah, you get smarter, but you also have to be able to learn and not internalize some of the negative stuff that you learn. And that's adulting. Not let it hurt you. And it's tricky. It has to inform you. That's the lesson. But you also have to find joy and keep going with energy, which I know you will.
So actually, what do you do specific work in Brussels, or are you doing the same work whether you're in Philadelphia or Brussels?
I'm generally doing this kind of work depending. I mean, in Europe, it's more of the food companies versus in the US, frankly. There's some very big European food people. The consumer electronics stuff is more Silicon Valley, maybe parts of Asia that I won't be specific about. So it's a mix. Retail and pharmacy is US. It's here. I admire what Boots does in the UK, and I'll be in London in a few weeks. And if I don't get a flu vaccine in the US, I'll get it at Boots. I already checked it out in London. It'll be a different formula, but it just depends when I can access and what I can access. And that's the benefit of travel. But no, it's the same kind of work. Scenario planning I can do from my computer and Zoom with clients all over the world. And I guess the benefit of being a digital nomad is some of these companies have workers in every time zone. So sometimes I have to do a meeting in the morning and a meeting late in the day for folks in Asia. And then we come together at some point on a Slack or a Teams notes. So the technology helps one work globally in that way. And that's why the nature of my work doesn't have to change.
And what advice would you give to your 17-year-old self?
Be the smartest girl in the room. Work harder than anybody. Stay joyful. Have other things to do besides work. A life sport. Swim, tennis, walk, not run. Too many accidents running as you get older. I've seen it. I know it. But I think a life sport's important, and also a creative outlet. So for me, it's journaling. I don't go anywhere without my traveler's notebook. This is August, and I journal on the day, things that I'm blessed about. There's the woman who hired me to move to Philadelphia, Ann Wright, and we shared a birthday lunch last week, me and her, and I carry my little HP Sprocket printer with me to print out, because all those photos are on your phone. This is cognitive therapy for mindfulness, and it's a thing. I'm doing a lot of research on this now because I am doing more of this on Zoom with people all over the world, journaling together, and I think I'm going to be growing that part of my life over the coming couple of years to work with younger women like you and older women like me and journal together and share. It's coming together in my mind as a really important way to mentor, but also learn from you. You're awesome. And I know many young women who are just awesome like you that I could learn from. Like, who am I to say I know it all? I don't. And so you can also help bring joy and energy and the fresh eyes to what we might be cynical about in our lives, older women. So yeah, this intergenerating, I'm doing more research about, because I'm worried about social health. Physical health, mental health, financial health for women is very tricky now because women earn less over the course of their years and they live longer than men. So that's something I've been writing about a lot. But then this issue of eating alone post-COVID, I've been studying from bowling alone, which we learned before the deaths of despair started to take hold in the U.S., accidents, overdose, fentanyl. There was this book by Robert Putnam called Bowling Alone about the demographics of who are these people who are bowling alone, who don't have the social fabric in their life. COVID made that worse because we were staying home and not going to work. And so we were literally bowling alone. Now, the National Restaurant Association in the US is telling us that 3/4 of the food that restaurants produce in America leaves the restaurant. So people aren't eating together in restaurants. They're taking it home, eating in front of the TV, the computer, the gaming console. And like, whoa. When I got that statistic last year when I was doing a talk about the new social determinants of health, that gave me pause. And I started to think about my journaling with women all over the world, in Utah and in Japan. And I said, there's something here for me to, on the social health front, especially for women. I have a daughter who's older than you. And so she's informed my looking at this as well, seeing how she's matured through college and then in her career. And in COVID, working from home was really tough. So I want to keep growing and doing something in addition to what I'm doing that could give something back, but frankly, be joyful. I've used that word a lot for me too, because we all need that ongoing as part of our daily prescription of life.
That book was beautiful, and having a positive book about your life and yourself must really improve mental health as well. I love that idea of interconnecting generations.
Well, I'll be in touch with you.
Yeah, do.
You're exactly who I think about. Like, what young women would benefit from this, but also have a lot to give? And how do we come together? And the technology can help us do that. So I am devoting some thought to it.
You know, it's also the same as like this podcast, because there's so much people can learn from people ahead of them in their career. That sounds great. And if there was a young girl that wanted to pursue health economics and she hasn't started college yet, or maybe she's in the middle of college, do you have any advice for her?
So economics first, get your arms around that first, because it's not easy. But if you have a brain that works right and left brain together, creative and analytical, it's a science to pursue, particularly if you're interested in people. Economics isn't about money, really. It's about scarcity and how do you allocate resources. And if you care about that, then take that first economics course, which could turn you off, because we know in most universities, the first economics course has thousands of people in it in a big auditorium. So then take the second class. At the same time, I think it's good to read. So either from the library, get a copy of The Economist, read the Financial Times, the FT, Barron's, the business paper. Read, take it in. Books out of the library, the old school books by Milton Friedman, even Karl Marx on capitalism. There's so much theory and history to learn from, in addition to the current books by the Paul Krugmans of the world, and Schumpeter on religion and the rise of capitalism. Fabulous book. So yeah, I'm really wonky about that. But I think reading, learning, talk to the teachers, the professors. I can certainly give you a list of some of those resources we can put on your website with this blog, some of my recommended readings. I think, I started subscribing to The Economist, which is not a cheap magazine to subscribe to, published obviously out of the UK, but has a huge US press as well. But it's an investment you make in your own human capital to read from cover to the end that magazine, because it's a good balanced view of the world. I think the US, but also Europe and Asia and Africa and India and China. And we need now, if you want to do economics, whether health or just economics and macroeconomics in general, you have to know about all of that. It's an integrated, wonderful thing, economics to me. It's a systematic way of thinking and organizing a lot of thoughts. So if you have that kind of brain and interest, and I think you do, that's where it's at. And we need more women in economics, because women are the chief household officers in the home, whether you're in Africa or whether you're in Miami. Women make decisions about resources for their families. So that's really where my original interest was, is in that human capital of the family in the work of Gary Becker, the Nobel Prize winner out of University of Chicago. His work for me is, if I had to pick one guy or woman in economics, it'd probably be Gary Becker on the human capital of the family. Fascinating work.
I'll look into that for sure. And for any students out there, there is a student discount that you can get, so The Economist can be a bit cheaper than the original price tag.
Yes, we believe in coupons.
Yes. And just wrapping up for the last few minutes, I was looking ahead. What excites you most about the future of healthcare? And where do you see the greatest opportunities for transforming health into a system centered on people and value?
So I'm not going to say AI is what's making me happy, because it's not in terms of the future. I think AI is going to be like the internet. It's going to be part of how we do our work. But I don't see it as the product, and I think that's a dangerous way to go, to lead with technology. What do we try to accomplish? How do we get there? What to me is transformative is what we're starting to see. The home as the hub of health. In the kitchen, in the bathroom, in the bedroom, in the living space where we can share knowledge with our families, tell stories, do jigsaw puzzles together, offline. Food as medicine, huge. Channel healthy food out there, incentivize farmers, de-incentivize the sugar people. But I think the home is a health hub, self-care, the way we used to do healthcare before insurance came in World War II in the US. So I think, and then teaching doctors about prevention, incentivizing them for prevention, primary care, and reallocating the money spent in healthcare upfront, up the pipeline to prevent the downstream risks. Moving out of the expensive university settings, which should only treat the sickest of the sick, but treat all the sickest of the sick.
Fantastic. Thank you so much, Jane, for coming on the podcast. I've loved this conversation.
It's a pleasure. Well, I'm glad I have a new friend in Alana now.
Thank you.
Thank you.
That's a wrap on today's episode of From Girl to Great. Here are the top 3 things we learned from my conversation with Jane Sarason Kahan. 1. Build a career by following the questions you can't stop asking. Jane's path is a reminder that curiosity, reading, and going outside of your comfort zone can turn into real influence. 2. Innovation means little without access. The US often leads in developing new treatments, but many people still struggle to access basics like primary care and preventative support. Jane keeps bringing us back to the fundamentals, the social determinants of health, like education, primary care, and the conditions people live in, shape health long before someone ends up in a hospital. 3. If you want to change healthcare, don't start with the shiny tech. Jane's not anti-AI, but she's very clear. Technology is a tool, not the goal. What actually excites her is the home becoming the hub of health, food as medicine, and a system that pays for prevention instead of waiting to pay for a crisis. If this episode made you think differently about what a career in healthcare could look like, follow From Girl to Great wherever you get your podcasts. And make sure to check out our website, fromgirltogreat.com, to learn more about what our organisation is doing and how you could get involved. See you next time.